Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, good afternoon, good evening, my colleagues. Thank you, Dr. Osama, my dearest colleague, for the nice introduction. What if I tell you that there is a condition or disease that can increase your patient's mortality 10 times? That if your patient develop this condition, there is 10 times more likely he or she will die during that admission. What if I tell you that that exact condition or disease actually is preventable, meaning that if you do simple intervention, you can prevent that disease or condition. You can save your patient's life. You can avoid your patient to be a dialysis dependent patient throughout his or her life. So with that, welcome to the acute renal failure talk. I would like to thank the organizing committee for having me talking in the second virtual international pediatric conference. I have some good news and I have some bad news for you. The first good news, acute renal failure is an old name. Nowadays, we don't call it acute renal failure. Nowadays, we call it acute kidney injury. Okay? So failure nomenclature, which is an old, discrete nomenclature, is back in the history. Nowadays, we call it injury. What does that mean? Injury is a continuum of stages of injury, A, and B, actually, some of these patients can have normal kidney function afterwards. So that's the first good news. And I will have some bad news for you, but stay tuned. Over the next 15 minutes, I'll try to go over some aspects of the acute kidney injury, and I'm going to use AKI for an abbreviation. So we're going to try to go through epidemiology of AKI, definition, workup management, and prevention. The first question, is AKI bad? To answer this question, I'm going to give you two facts. The first fact, having AKI increases the patient's mortality more than 10 times, meaning that if your patient develops AKI during admission, he or she is 10 more times likely to die during this hospitalization. This is number one. Number two, long-term complications. Yesterday, we listened to a beautiful presentation by Dr. Abu Bakr Imam, a great nephrologist. He talked about hypertension. This is one of the long-term complications after AKI. 1 out of 5 patients after they develop AKI, they develop chronic kidney disease. Different stages. Some of them need dialysis. Some of them, they live without dialysis. Approximately 1/3 of these patients develop hypertension. Now, next, how do we define acute kidney injury? How do I know my patient has acute kidney injury? There are several definitions. The most widely acceptable definition is the international definition, the KDIGO guide, the KDIGO definition. And I don't want you to memorize all these numbers you see in front of you. It's really hard to memorize, but I want you to look at the first row. Look at the first row and focus on these simple numbers. If my patient had a creatinine yesterday of, let's say, 60, and today 1.5 times that number, or an increase of 27 micromole per liter, or a urine output less than 0.5 over 6 or 12 hours, then I need to worry because my patient had AKI. So start with that simple line, and anything above that, you need to worry about your patient because your patient developed acute kidney injury and he or she at risk of all the complications we mentioned. This is a bad news. This is creatinine, which we still use. Creatinine was first used to diagnose kidney dysfunction or to assess kidney function, was first used in the 1960s. And now we are in the 2021, 60 years after that, and we still use creatinine. Creatinine is a terrible test. It's delayed. Number one, it's delayed. It takes days until it peaks after the injury, and it needs a substantial injury of a substantial number of nephrons to be injured in order to rise. Because think about it, you have million nephron on your right kidney and million nephron in your left kidney. If you have an AKI, you lose, let's say, 500 nephron, 1,000 nephron. The other nephrons will compensate. So you will have a normal creatinine. So number one, it's delayed. Number two, it's inaccurate. It's affected by muscle mass. It's affected by protein intake. It's affected by some medications. Even the athletes, when they take creatine for building muscles, that can affect your creatinine measurement. And the third one is even in children, it's even worse because the kidneys are maturating during the first couple of years. And so that maturation is going to affect your kidney function. And not only that, but during the neonatal period, some of that creatinine is actually not the child creatinine, it's the mother's creatinine. It just carried over to the child. So several limitations, and again, creatinine test is really a bad test and we as nephrologists, we know this fact and we admit it. Now, is there hope? Yes. Alhamdulillah, always there is hope. There are several novel new biomarkers that are being studied and being developed as we speak. As you can see in this graph, there are several new biomarkers that are being studied, and until now, none of these is being used clinically, except the last one in adults only. But hopefully, in the near future, we will see that being used. Now, let's move. Let's say we have a patient. This patient developed AKI. We had a creatinine of 60, and next day it's 150. What do we do next? The first goal is to differentiate between pre-renal and renal and post-renal. And I know we all remember this from medical school, pre-renal, renal, and post-renal. And again, we say that all the time because it's really critical and important to differentiate between the three because the management is totally different. When you talk about the pre-renal pathology of, let's say, impaired perfusion, dehydration, bleeding, whatever, you need to give them lots of fluid because you need to improve the intravascular volume and perfusion. Compared to the post-renal, when there is an obstruction, let's say an anatomical obstruction, a stone or whatever, the main focus is going to be to relieve that obstruction. Now, in the middle category, which is the renal, the intrinsic renal diseases, that's where we say we're going to use our supportive measures, and we'll talk about in a few seconds. To work up someone with acute kidney injury, you need to do these 5 things. Take a good history. Do a good physical examination, and then take basic labs, electrolytes and blood gas. Take a urine sample for urinalysis and urine protein creatinine ratio, and then do a kidney ultrasound. If you do these 5, I guarantee most of the time you will know at least which direction you are going to, renal, pre-renal, post-renal. And then after that, you can think of what's next, but at least start with these 5. And I stress the importance of history, good history, and good physical examination, including the vital signs, the blood pressure. Make sure you know how to measure the blood pressure. Listen again to Dr. Abu Bakr Imam's lecture from yesterday, a great lecture about blood pressure and hypertension. Here is the good news. In pre-renal pathology, and this is the most common cause of acute kidney injury, pre-renal azotemia is usually rapidly reversed by restoring the renal perfusion. Okay, now let's move to the management. Now we diagnose our patient, and now we want to manage this patient. Again, as we said earlier, if it's pre-renal, you're going to give them lots of fluids, restore the intravascular volume. Post-renal, you will relieve the obstruction. What do we do with the renal, the intrinsic renal? pathology. Now, the KDIGO, the international collaboration, the international guidelines, they have a good algorithm or a good suggestions for management strategies depending on the stage. So starting with the early, with the mild stages, you discontinue nephrotoxic medications, you monitor the volume status, you monitor the serum creatinine and urine output, etc. That's from the beginning, and then at the end, it goes all the way to needing a renal replacement therapies in the advanced stages. Remember the job description of the kidney. What's the job description of the kidney? Kidneys do these things: acid-base balance, water balance, electrolytes, toxin removal, blood pressure control, erythropoietin, and vitamin D metabolism. When a kidney doesn't do its job, your job is to support that kidney. You manage, if they can't manage the fluid, you do a fluid management. So if the patient is hypovolemic, you give them fluid. If they are hypervolemic or fluid overloaded, you restrict the fluid or you do some fluid removal. You manage the electrolytes, you manage the acid base, and etc. I want to stress out one point here, which is kind of a bad news, but at the same time, if you know it and you pay attention, you actually hopefully you don't have trouble with. Sometimes we start with hypovolemia and pre-renal pathology, and the patient is dehydrated. And then we advance and we go into what's called the acute tubular necrosis, the ATN. That condition, that situation, the kidney does not respond well to fluid resuscitation. When you give the patient fluid, the kidney is not able to excrete that amount of fluid because the tubules are necrosed and all these cells are dead. So if you give them fluids, you actually might kill your patient. And I stress that point. You might kill your patient. Because think about it. If you give fluid and the fluid, there is no way to go out, but the kidney is not working, and then you have this ATN problem. Where is that fluid is going to go? You're going to have extremely high blood pressure with all the problems that can happen, including stroke and all the badness. You can have pulmonary edema, and the fluid will go to the least resistant area, which is the lungs. So you might have pulmonary edema, and we've seen this. Some patients need to go to the ICU and put on ventilator because we're given tons of fluids and they are in the acute tubular necrosis phase. So pay attention to a patient who comes early from the beginning or only with hypovolemia and pre-renal pathology, and you give fluid and they don't make urine output. Once you give fluids and there is no urine output coming out, that's a red flag. After that, if you don't pay attention to that red flag, the first even more red flag is going to be development of edema and hypertension. And if you don't pay attention to that one, you will see your patient, unfortunately, maybe in the ICU. Okay? So this is really something important I wanted to stress out. All right. Sometimes, in some situations, our conservative or supportive management doesn't work. So we need to do some sort of renal replacement therapy, like hemodialysis, peritoneal dialysis, renal replacement therapy. This is beyond the scope of this talk, but I just wanted to mention it so you are aware of some situations we need to go in that route. All right. Now, let's shift gears from having a patient, I want to diagnose, I want to know what's wrong with this patient, I want to manage. Now, let's move to another view. Let's think about how do we prevent this problem from happening? And instead of waiting for the problem to happen, how do we think proactively? And so before the acute kidney injury happen, how do we think proactively and prevent that? I'll give you some ideas and some examples. The first one, something called renal angina index. It's a prediction model. It's a widely used internationally. It's a prediction model. You use it to stratify the patient risk for developing AKI, meaning that you are in the inpatient, you are receiving, let's say, 5 patients. In that night, you are on call. You put the renal angina index and you say, well, the first 2 patients are moderate risk. The second 2 patients are high risk. Then the last patient is very high risk. That means that that patient or the last 3 patients need more monitoring and more caution, and you need to pay attention to their even more attention to their fluid status, vital signs, intake and output, etc., etc., etc. So you need to be really vigilant with these high-risk patients. This is the first example. The second example, you can use the electronic health record to identify which patient from the beginning, which patient will go and develop acute kidney injury. This is an example of an EHR, electronic health record based prediction model. This is actually a real patient. Let me put the pointer. This is actually a real patient. She developed an AKI at this stage, at this point in time. She developed AKI, per definition, from 0.6 to 1.1. Okay? What happened before that? Let's go back and see what happened. She got a loop diuretic. She had a glucose. Glucose went up and down. She got blood transfusion. She had blood glucose is going fluctuating. Sodium bicarb was given. Glucose was also changing. Creatinine went up a little bit, and then she developed AKI. Now, your prediction model, which you programmed in the computer, identified that this patient is at risk at this time, this point in time. So you have several hours before that patient developed AKI, and you can do something for that patient before he or she developed AKI. Now you can ask me, well, what do we do? If I know my patient is at risk for developing AKI, is there something I can do about this patient? Or will I just leave the patient and see what happens? I may give you a great project called the NINJA project. It's an abbreviation for nephrotoxic injury. Nephrotoxic injury negated by just-in-time action. This project was done by by Dr. Goldstein in Cincinnati. A great idea, a smart, simple intervention. And remember this. This is a simple intervention. They programmed the computer system. Whenever there is a patient receiving 3 nephrotoxic medication or an aminoglycoside for 3 days, a message will go to the pharmacist. The pharmacist will receive the message. The pharmacist will go to the clinical team. They will sit together. They will discuss. Does this patient need the nephrotoxic medication or no? If they need the nephrotoxic medication, let's say aminoglycoside, okay, well and good, they will continue. If they don't need the nephrotoxic medication, let's stop that medication. Very simple intervention. Just the pharmacist goes, sit down with the team and discuss. Guess what happened? They decreased the AKI rate 64% in less than 1 year using this simple intervention. They went down by 64% in AKI rate. You can imagine how many lives they saved by just doing this simple intervention. And this is a message, and let me stop here for 1 second. This is a message for each one of you. You are a pediatrician, you are a resident, you are a student, whatever your specialty you are. Think about creative ideas and think about not only creative, but simple ideas that can really have good impact on your patient. Like this one, very simple idea. They decrease the rate by 64%. And obviously, After that, most of the hospitals, I wouldn't say most, but many hospitals in the United States, they adopted this system. Very simple intervention. All right. Now, let me summarize. I'm gonna summarize the 5 good news I told you and the 5 bad news. The 5 good news about AKI. It's injury, not failure. Azotemia, which is the most common cause of AKI, it may be reversible, and your patient might have no problem afterwards. You use a very simple approach, which is pre-renal, renal, post-renal. Very simple. Early recognition can improve outcome. And then the last one, we have some promising novel biomarkers. The 5 bad news, very high mortality, acute complications, acute life-threatening complications, might need dialysis. Bad long-term complications like CKD and hypertension, etc. Diagnosis, we still use creatinine, which is terrible, limited and delayed, and etc. And last thing, which I stressed, not all AKI treated with fluids. Fluids can be harmful. With that, I conclude, and I'm more than happy to receive questions, either here or if you have any questions in the future, please, you can reach me. And if you would like, you can send me a message and I can send you the whole presentation along with the PDF versions of all the studies I cited in this talk. Thank you.
Thank you, Dr. Sandokji, for an amazing presentation on how to deal with AKI in pediatric patient. While we are waiting for the questions coming from the audience, I want to see your perspective regarding the novel biomarker. As a clinicians, usually we facing challenging regarding the novel biomarker, regarding the time to process the test and the cost of the test. Sometimes it's not applicable to use it in real practice. So.
Yes, thank you, my dear colleague, Dr. Osama. This is a great question. Unfortunately, none of these biomarkers is in clinical use. None of them is in clinical use. The one that hopefully will be in the near future is the NGAL, and that. But again, it's not easily accessible, and it's also anything new you need to pay for, and it's not as cheap as creatinine. Now, that's a problem. Now, let's think, how do we deal with our creatinine? Okay, we know creatinine is terrible, so what do we do for that? If you know the creatinine doesn't go up until substantial injury happens, let's say until 24 hours or 48 hours until the creatinine goes up. What you need to do when you are in the ICU, let's say, or you are in the emergency room, and you have a patient, and this patient's creatinine is normal, but this patient's hemodynamics is bad, and you are giving them all kinds of nephrotoxic medications, and on top of that, you're giving them some contrast. You should know that the creatinine does not reflect the kidney function, because that creatinine at that point in time is not actually the actual creatinine, and there is an ongoing injury. You are not seeing it now, you will see it 24 hours later or even 48 hours later. So just put that in mind, is that even though I don't see a rise in creatinine, that doesn't mean there is no ongoing injury. I need to be proactive, and I need to understand that fact.
Great. Thank you, Dr. Ibrahim, for this presentation.
الأكاديمية الطبية الافتراضية، اختيار جديد. medicalacademy.org